So 6 months after we first released the guideline, we interviewed key members of staff in each of the NHS trusts and local authorities that had helped us to develop them. And we asked them what had been their experiences of using them. They were all at different stages in embedding the guidelines, partly because of their own priorities and partly because they focused on different areas of the guidelines that they particularly thought were necessary. So it was very encouraging to hear that practitioners liked them. They liked them partly because they had come to realize that there were shortfalls in practice, and they felt that the guidelines had helped them to focus on very vulnerable parents in difficult situations and try to address their needs. They helped them to empathize with parents. They helped them to follow parents through their journey. The small acts of kindness were also very well received. Little things like giving mothers who had very little opportunities for control in their lives, giving them choices about, for instance, the sort of formula that the baby would have if the baby was placed with foster carers, or what the baby would wear when they left the hospital. Those details were very important to the parents, and they helped them. They helped them get through this very difficult situation they were in. 6 months after the guidelines were published, managers had also made a number of organisational change to facilitate implementation. Almost all the authorities had brought forward the timescales for referrals to children's social care. They were now accepting them in the first trimester of pregnancy. If mothers are referred late in the pregnancy, they have very little opportunity to access the type of services that might help them overcome the difficulties that place the infant at risk of significant harm. But if the referral is accepted in the first trimester of pregnancy, and of course, if it is then followed up by assessment and provision of services, then mothers have a much better chance of being able to overcome those difficulties and offer a safe and nurturing home for the baby. Another change that we thought was likely to have a major impact was the introduction of multidisciplinary pre-birth teams, or at least dedicated members of staff who could focus on the unborn child. Those practitioners quickly developed a specialist knowledge of the issues that such parents faced, and they had more time to focus on the pregnant mother and to meet her needs. And up to 6 months after discharge, offering the sort of continuity that was clearly very important and had been very difficult to achieve before. And then some of the authorities had introduced pre-birth family group conferences. Now, several of the authorities had introduced such conferences in the third trimester, just before the baby was born, when it had become evident that the mother might not be able to keep her baby. And those conferences had focused on which family member might be able to provide alternative care. But these very early pre-birth conferences took place in the first trimester, and they focused on which members of the family might be able to support the parents and provide that sort of that additional care that they needed in order to overcome their difficulties and provide a nurturing home for the infant. Of course, there were challenges, there were difficulties in managing change and in implementing it. There were resource issues, for instance, difficulties in finding staff available, making dedicated time available. There were concerns about staff turnover. However, the overall conclusion, our conclusion was that in those local authorities and NHS trusts where there was a firm commitment to engender change at all levels of the organisation, then it was possible to make the sort of changes that the local authorities were trying to implement. We think that the guidelines have the potential to make a real difference for these very vulnerable parents and for their infants.